Welcome everyone to today's webinar, How Patient-Provider Relationships Affect the Success of Your Value-Based Care Program. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, I'm pleased to introduce our presenters. James Lawson. James leads NASCAID's external operations with over 20 years of experience in healthcare technology. James excels at building and leading client-facing organizations for companies ranging from startups to large established corporations. Bob Pirtle. Bob has over 10 years of healthcare experience with pharmaceutical, hospital, commercial, and government payer organizations. He collaborates with stakeholders to identify, develop, and execute strategic solutions to successfully operate in the new economy based on data transparency, patient care, and population health. James, the floor is yours.
Thanks, Brian. Appreciate it. And thanks to all of you for joining us today. We hope we'll have some interesting tidbits for you. And as Brian indicated, we will look forward to some Q&A. With that, let's go into the agenda real quick. At a high level, we'll do a little bit of an introduction on our company, NASCAID, and kind of what we do and kind of how it fits into the topic today. We'll talk a little bit about a concept called the streetlight effect and how that also plays into kind of how we view things and how you can view things moving forward. We'll talk a little bit about relationships, kind of the key topic today, and how that is playing into value-based programs. Then we'll move into how do we calculate and measure relationships. Finally, we'll talk about how some of the relationships can be placed into action, how this insight can be put into play in value-based programs and beyond, and what we're seeing right now. And then finally, we'll wrap up quickly at the end, and hopefully have some by that time some good Q&A that we can transition into. As Brian introduced us in the beginning, my name is James Lawson, and I'm joined with my colleague Bob Pirtle. We're going to do a little bit of a interesting take today, in that I'm going to do a little bit of a question, almost like an interview with Bob. Bob's been with NASCAID, or is with NASCAID now, obviously, but he's also held some leadership roles in ACO, and so I think his perspective is unique in that he's seen what we obviously offer, but he's also come from a leadership role recently, and so he kind of has a little bit of a unique perspective in that. He can see it from, sitting in the chair of somebody who was managing some of these value-based programs not too long ago. And so we'll use that as kind of a little bit of our guide in our journey. So a little bit about NASCAID. We are a data and analytics company. We are a smaller startup organization, been around about 5 years. But I think the interesting thing for us is that we've all had a lot of experience in various value-based programs. And in essence, what we found in NASCAID on was to try to take a new insight and look at ways to make value-based care a bit more effective and a bit more efficient. And so we're basically applying all of our experience to looking at data in new ways, trying to leverage tools that already are in place, but do it in a slightly different way to allow you to get maximum benefit out of value-based care, and frankly, try to strive for what everybody ultimately is driving for in those programs, which is higher quality and lower costs in the end. So we have a lot of different ways we do that. One of the ones we'll talk about today, obviously, is looking at relationships, but certainly relationships and behaviors are a lot of what we key on. How somebody accesses the system tells a story, just as the relationships that they have within the system tells a story as well. So again, those are the topics that we'll focus on today, and as it relates to our company, NASCAID. So let's talk about the streetlight effect. Some of you may have heard this. It really kind of starts with a story. And it's essentially a man loses his keys and it's dark outside. He starts searching for them under a streetlight, which you can see there. Before too long, one of his friends comes over to help, and they're continuing to search. And eventually his friend says, are you sure you lost your keys here? Because we can't find anything. And the man answers back, well, no, actually, I lost them in the park. And so the friend says, well, if you lost them in the park, why are we looking here? And the man answers, because this is where the light is. And it's really just a short story to describe what's known as really kind of an observational bias. And it's known as the streetlight effect. And it really indicates that we often look for things where it's easy to look for them, not where it's necessarily effective or important to look for them. And certainly this is not limited to healthcare. We found this, there was an article the New England Journal of Medicine published in 2019 that was really kind of driving at this to say, sometimes the data is there. We have to look at it in a way that is outside of what we may have done historically. And so I think from that perspective, it drives a lot of kind of what we are looking into and what we frankly want to talk about with you all today. But before we go there, I mean, we've talked about this, we've described the streetlight effect. Bob, in your previous roles working with ACOs and even other payers for that matter, have you seen examples of that come up?
Yeah, hi, James, and good afternoon, everyone. I appreciate you joining our discussion today as well. And yeah, throughout my career, James, I've collaborated with payers, providers, government agencies, and really the focus was on developing, deploying, maintaining, and evolving value-based programs, doing that using various data assets and policy parameters that would achieve the goals of those respective organizations. As you mentioned, my most previous role, I was the executive director of a population health services organization that provided people, processes, and technology, which was part of the organization Centris Health, Kansas City. That organization consisted of over 2,000 physicians. We had approximately 50 provider practices that were part of local health systems, as well as roughly 35 independent provider clinics. And this collective group had value-based agreements with Medicare, some commercial agreements, direct-to-employer agreements, and roughly comprised or resulted in 165,000 covered lives. And so, to continue the background, we would build data assets using clinical and claims data with the effort focused on creating analytics and dashboards and patient-level reports to help our constituents identify and drive contract performance opportunities tied to our contract incentives. And by and large, these measures were clinical and utilization-based quality, focus on overall utilization, network integrity, or identifying ways to keep our attributed population within our ACO ecosystem, and then finally, the overall total cost of care. And historically, we would look at performance across multiple hierarchies, if you will, so identifying performance opportunities and variation at the ACO level, but then being able to peel the onion back and look at it by a system, a group, and ultimately at the practitioner level. And then finally creating actionable patient lists to deliver to our participants so that they could understand the opportunity and, most importantly, take action on it. And, I'd venture to say that our approach was, it's not rocket science, and would think it's very consistent with how other organizations approach that, and that you try to identify the 5 to 10% of the people that ultimately were driving 95% of the performance for each of those measures within our contracts. So what we, discovered, we prided ourselves on being a test and learn organization in that our organizations excelled hands down and really knocked the ball out of the park related to clinical quality. And those would be the typical measures that, organizations would be familiar with, like HEDIS measures. And, that was a result of their own EMR and workflow clinical data use that was front and center with the provider as they were interacting with their patients. Conversely, while we excelled at clinical quality, we found that there was always opportunities to improve utilization-based quality, and typically that was based on claims data that we'd get from our payer partners. So focusing on things like ED visits per 1,000, being able to identify soft admissions, and again, that concept of network integrity and keeping our patients attributed to our care within our system so that it would ultimately drive an improved cost of care trend. And as this evolved over time, we would hear a lot of this challenges that I'm sure many organizations have experienced of data overload, having to manage multiple lists organized by chronic condition or by payer, being able to get those lists in front of the participants for them to take action on. And while for the most part we're able to create some standardized reports that had decent uptake with our physician leadership, we felt there was an opportunity to create cleaner and more efficient ways to view that data that kind of turn the lens or refocus the lens from a metrics-based perspective to more that focused on the entire person or a person-centric view. And this was especially true in trying to reduce the reduction of total cost of care because, as there's a little bit more nuance in looking at cost of care, given that there's not a single lever that you can pull that's going to have a direct impact in reducing that total cost of care. It's really a combination of different tactics and different factors that's ultimately going to decrease that cost of care for the organization going forward. And so in a sense, for us, the streetlight effect was measuring and documenting and submitting that information which would be to quote unquote complete a measure, which is certainly key and a very important component of any value-based agreement. And that process resulted in tangible indicators of success. We could clearly see if the measure was met or not met, a visit did or didn't occur, and with those measures, there are specific tactics that we can address. If somebody's not captured as having an HbA1c test, you call them to get them in. If it's time to get them in for their annual wellness visit, you reach out to that person and get them scheduled. Same things for cancer screenings and the like. But as I mentioned, it becomes more nuanced with claims-based measures in that there's not one box or one test that we can check that's going to directly correlate to a cost of care reduction. And so again, while it's critical to measure and manage those clinical measures, it doesn't always correlate to an improvement of the overall value-based care objective, which, by and large is to improve the cost of care while providing a positive patient experience that's going to drive that clinical outcomes that we're driving with through that program.
Yeah, so that's a great point, and I think you highlighted this notion of streetlight effect well, Bob, in that you're tracking and you are looking at measures, but ultimately those measures might not translate to the ultimate objective, right? That we talked about, which is at a very, very high level, better quality and lower cost. So given that, how do you expand beyond that? In your organization, obviously you had some ideas. What is it? What does that evolution look like? Whether you accomplish it or not, what does that look like on a case-by-case basis?
Yeah, I think at a high level, James, it's the continued focus and education around the whole person or kind of continuing to turn that lens away from the encounter and focus on the person. And we do that by increasing our understanding of underlying factors like the social and clinical and healthcare factors that influence a person's behavior. We can leverage that information, again, to identify how we create more stickiness with that person and their practitioner. And I think we can increase our understanding of that person and what's driving that behavior. And by one of the ways that we're going about that is this notion of relationships, and that we're able to calculate, measure, and apply those relationships to people that have primary care practitioners that could potentially be the connector, if you will, across multiple data points that could inform which people need the additional support. It can help refine the type of support that they may need, and then gives organizations the ability to track track the impact of any additional outreach that they've done over time to see what kind of progress that creates. And then I think this notion of relationships starts to treat the person as more of a consumer of healthcare. And we can use relationships in the same way that other kind of organizations or different industries use, really, in terms of consumer data to inform tactics and outreach and engagement with those quote-unquote customers that they're ultimately responsible for within their program.
Yeah, I think that's a good point, right? We've talked about it before, but this notion of engagement and how people engage with the healthcare system, it tells a story. Now, it's going to take a different view in terms of looking at it and interpreting it, but I think there is value there. So, okay. So we've talked a little bit about this notion of the streetlight effect, but let's also kind of get into more around, kind of the current state, if you will, of value-based care. It's complicated. There's no doubt, and there isn't, kind of a uniform approach. And I think that's part of one of the challenges that we've got. But at the same time, I think everybody agrees that as we migrate toward kind of this notion of a whole person, you start to open up things like relationships and behavior. So, in your mind, Bob, how do you see kind of this notion of whole person care incorporated as it exists right now?
Yeah, I think for us, James, we see more of an emphasis on how the social and behavioral factors impact outcomes and how they can have an influence on clinical and disease burden. And we see more information being shared about that kind of that notion of, healthcare outcomes are, while the encounters themselves have an impact on a person's outcome, there's certainly more beyond what happens in the healthcare setting that's going to have an impact on that person's social treatment and clinical factors. And I think that ties into this quote from Paul Keckley, in that the organizations are starting to think more about what services they have and what's necessary to manage a person's complete care throughout the continuum that accounts for any and all factors that might drive that person's behavior when it comes to healthcare or interacting with the healthcare system. A challenge, but I also think is the opportunity, is creating this notion of a longitudinal view of a person's interaction with the healthcare ecosystem. And what I mean by longitudinal, we're talking about analyzing multiple years of data to create a more complete picture of a person's use of services over that time period, which we think we can then build or use to build a comprehensive profile of that person that gives us more context about them, and use that information with their practitioners, which can then in turn help them potentially tailor those engagement and interventions that address that individual person, or in many cases, a cohort of people's specific needs. And we think that becomes the foundation of this notion of stickiness between the practitioner, the patient, or the relationship. To the extent that organizations can tailor those interventions that account for that whole person concept, this may then motivate that person to become more connected with that practitioner or care delivery team instead of cycling throughout the system, bouncing from multiple EDs or urgent cares or other practitioners. And we think that relationships can help inform that process. And James, if you're speaking, you might be having a connectivity. Yeah, there you are. Go ahead.
Yeah. I was going to say, and we talk a little bit about this notion of relationships, but I think generally speaking, the feedback that we get from our clients is that everybody is looking at that as a positive indicator. But in reality, how do you see relationships being used today, and how can they evolve as we're talking about it in the context of these value arrangements?
Yeah, I mean, my experience with relationships in the context that we're discussing today was limited. Honestly, there's much more focus on, the core components of a program that relate back to attribution or member experience measures like CAPS, Press-Ganey, things of that nature. I think relationships become more important as organizations consider what their pathway is throughout the value-based care kind of evolution. We're hearing more or seeing more examples of organizations being asked to take on more risk, which means they need to have a higher level of connection with their panels in order to succeed in that higher risk environment. So I think this is kind of a newer way to analyze this type of interaction with the people and the practitioners that are delivering care for them.
Yep. And I think you raised a good point earlier about looking at this from a longitudinal basis. I think that the thing is that we've seen time and again is that relationships are not bound by contractual time frames. So it may be a contract runs for 12 months, but the reality is a patient-provider relationship spans years. And you have to make sure that you're not just looking at, kind of the information that's contained within that contractual time frame. And I recognize that it's sometimes easier said than done, but those are the kinds of things when we talk about the street light and looking beyond, exactly where that light is shining. That's where you start to get out, and there are pieces of information that often reside within your organizations today by virtue of claims history that we can use to kind of piece together and start to tell that story. So we'll go to the next one. So we've talked a little bit about, kind of the current state. Certainly, Bob, you and I have talked about, some of the challenges that you face, not only within your organization, but I think just across the board, whether that be payer or provider. But in your view, what are some of the key gaps that you've seen in the programs from a value standpoint that you've seen up to this point?
Yeah, well, and I think the comment that many people would hear is that if you've seen one ACO, you've seen one ACO. So each organization is going to have its own unique challenges. Ours would vary from physician buy-in within organizations or any of the projects that I was involved with to defining clear program goals and the methodologies that we would use to achieve those goals, incorporating analytics into workflows so that patient or providers had access to the insight about the people that were part of the program, and then ultimately that they could use to tailor programs to have success with the program. Generally, program design and financial incentives may not be substantial enough to drive true behavior change out of the gate. So, the primary focus was around clinical and quality utilization. And granted, there's lots of work that's been done over the last 10 years, and I think there's always room to improve in those areas. But by and large, those opportunities may be becoming smaller and smaller or more incremental, just given the fact that many folks have had a lot of success with that over the years, and there's not as much juice to squeeze, if you will, which I think leaves us with new opportunities to analyze different quality metrics, but also bring it back to the overarching objective in terms of mitigating cost for that attributed population. And there's also the never-ending challenge of claims lag with value-based care programs. While we can't solve for things like run-out, I think there's an opportunity to use that retrospective claims data to develop more prospective approaches and use elements potentially like relationships with existing metrics to refine which groups of people may benefit from targeted care engagement, kind of like what you just described, James, in that there's multiple periods of information that ties back to a provider in terms of their interaction with the patient that we can take advantage of. And then there's also this notion of scale, where you have many organizations that are kind of have their feet in two separate canoes still. The first being the fee-for-service canoe, which by and large still represents the majority of a practitioner's book of business, certainly drives their revenue from a system perspective if they're part of a large healthcare organization, and in many ways the individual provider compensation as well. And then you contrast that to the other canoe, which is this value-based care canoe, and that has smaller potentially smaller patient panels. Financial incentives aren't always completely clear to the provider, and even if and when measures are achieved, there's no guarantee that a individual provider will see any benefit or financial reward based on how they performed for that program. And then on top of that, you don't find out how you performed until the middle of the following year, again, due to the claims run-out issue that we described earlier. So, I think with all that still in play, it makes sense that practitioners and organizations are being focused on those areas with the biggest financial impact. And then some of the other challenges that we experience is that there's so many different touch points for a person as they're interacting with the healthcare system, and that's kind of a duh, no kidding comment, but from referral activity to scheduling to prescriptions, while it all rolls up to the primary care physician, there's so many more moving pieces and parts behind the scenes that really have to become aligned with what the programmatic goals are, and that really starts from on top and having that overarching emphasis placed on that program from the organization's perspective. And so, I think that's why having organizational buy-in from the top is key when it comes to these value-based agreements.
Yeah, and I think you hit on a notion there in scale, and I think one of the things that we've heard time and time again when we talk to some of the providers are that listen, the value-based programs are attractive in some cases in terms of the ability to partner for a better cause, but the scale of the overall kind of financial commitment is relatively small if you look at their overall book of business, and so there's this notion of also alignment. I think we continue to see people strive toward greater, kind of synchronization, I guess is maybe the best way to describe it. So, okay. So we've talked a little bit about, some of the challenges. What are, let's think through now some of the opportunities that may present themselves. And I think, we've hit on it a couple of times, Bob, but I think one of the things that we've seen on several examples recently where I think there's an appetite for folks to say, how can we incorporate this notion of relationships into programs that already exist? What are your thoughts on some of the opportunities that exist in order to leverage relationships as part of a value-based strategy?
Yeah, I think some opportunities goes back to that notion of analyzing the whole person and their interaction with the healthcare system in a singular view. By looking at relationships, I think that has the potential to break down silos internally as a patient kind of moves through the system for their care. Typically on the delivery side, we might see ED encounters to inpatient stays to having post-discharge follow-up visits with their PCP or maintaining visibility on the amount of services that might be leaking out of the attributed organization system. I think this longitudinal data that we use to create relationships helps to organize and consolidate those different data points into a comprehensive view so it can be potentially integrated with existing analytics. And then this approach could supplement existing care management tactics that are already in play. With condition-specific programs, we can layer relationships on top of those to identify patients with potentially weaker relationships with their providers that might be churning throughout the system, which again kind of helps us continue to turn that lens more towards looking at analytics from a person-focused view as opposed to a condition-focused view.
Yeah, and that's a pretty good segue because I think you're hitting on some themes, but beyond those, right? I think the notion of looking at it from a person-centric perspective instead of maybe a condition or clinical-only perspective is a key one. But are there other key themes that you're seeing as you talk to clients and just see other programs that are out there that tend to kind of incorporate either relationships directly or something similar to that notion?
Yeah, we're working with a health plan in the Midwest right now, James, that's exploring a new value-based program and how they can encourage providers and arm them to have success as they consider taking on additional risk. And as part of that, we're exploring how to integrate relationship strength with their existing metrics so that their healthcare participants have a better understanding of how they can really focus on the retainment of their attributed population and begin to treat them as consumers as part of this program. That's kind of one of the emphasis of this health plan's new program. And their hypothesis is that their healthcare organizations can retain and maintain control of the healthcare services their attributed population receives. It's going to benefit both the payer and the provider. From a provider perspective, it's going to set them up to succeed with the total cost of care targets that are established as part of that program, given that there will be more downside risk in play. If they're able to use that data point to come in below their target, they're going to realize savings and additional revenue from the health plan based on that optimal performance. And also from a provider perspective, and we consider this at Centris Kansas City as well, by maintaining those services for their attributed population within their healthcare ecosystem, that's revenue coming in the front door of the system as well. So both the payer and the provider can benefit from that. And then the payer benefits because that member has a better experience, it's a more consistent experience, and ultimately if it stays within that one system and they're able to manage and coordinate that care throughout their multiple providers, they're not churning throughout the entire network, and it increases the likelihood that the chronic condition or conditions that they may be experiencing is being treated in such a way that's going to mitigate future more intensive healthcare services down the road if that condition were to deteriorate. And then the health plans, I think, are starting to view relationships as a means to inform healthcare organizations on their patient behaviors and how they can use that information to supplement their existing outreach efforts. And it goes back to this notion of a longitudinal view of the person's history and how it can be integrated with other factors like social and clinical and treatment burden, and how the healthcare organizations could potentially enhance their quote-unquote at-risk patient cohorts. And those are typically those patients that might be using healthcare more inconsistently and traditionally or historically may not be as connected to their primary healthcare delivery team as they could be.
Yeah, it's a great point. And so at this point, what we've really done is we've talked a little bit about, kind of the current state in value-based care, some of the gaps. And then now, you're starting to kind of say, here are some areas where relationships can be incorporated and this notion of relationships. But, as I mentioned in the beginning, we're going to talk a little bit about how these are being deployed today with some of our clients and other instances. Before we go there, I thought it might be good for us to talk a little bit about when we say relationships, what exactly do we mean there? Because I think it can take a lot of different definitions, and it's a seemingly basic concept, but I also think it would be helpful for us to make sure that we ground everybody in that definition. So Bob, if you could, just talk a little bit about how we're viewing relationships and what goes into that.
Sure. So when we mention or when we use the term relationships, we're referring to or accounting for the longitudinal aspect, kind of what we discussed earlier, James, about the person's utilization for all their encounters for all sites of service with any provider and across multiple time periods, or in some cases, many cases, years of data. So at a very high level, we're looking at standardized visits, E&M visits, professional day visits across multiple sites of service. We're looking at primary care providers in many of the same ways that folks would be familiar with attribution methodologies. And then we're also accounting for visits or encounters to specialty providers as well. And so by looking at this longitudinal view or using this retrospective view and looking at those encounters with those physicians, this gives us an ability to be proactive and taking a prospective approach based on that historical information and gets us beyond just the prior performance year, which might be more choppy, I guess you could say, versus looking at multiple periods of data that give us more context on that person's encounters. And not only can we derive relationships from this longitudinal view, but we can also begin to segment a large population into similar cohorts based on their different risk factors. So this may include things like relationship strength status, but it could also include health risk factors, social factors, including whether or not people are living in deprivation or vulnerable socioeconomic status areas. And then also certainly accounts for existing treatment and clinical factors that may have an impact on cost and outcomes.
Yeah, it's great, and I think we'll probably learn more in another slide or two just about how some of that stuff can be deployed. But let me ask the obvious question here. What are the data considerations, and how does that play into this? Because obviously that's kind of foundational to what you're going to need in order to assess this.
Yeah, I mean, and it's no question that data certainly plays a critical role as far as relationships go. But at the same time, it's leveraging or it's based upon the same data that organizations are using today for their existing value-based programs. So our partners that we work with today are, in commercial and also Medicare, ACOs. So we're leveraging a lot of the standardized claims data sets that would be readily available from existing payers, and that providers are also very likely receiving as part of their relationships with their payer partners as it relates to their existing value-based programs. So while it's a new kind of concept or a new way to calculate or leverage that existing data set, the nice news is that it's not, doesn't require a lot of heavy lifting on the part of our provider or our partners, because it's the same data that's already in play today, and in many cases is being exchanged with other organizations as well. So, the specs that we use are very consistent with, more standardized specs that industry players are experienced with.
Yeah, that's a great point. And I think, I'll just emphasize that from our perspective on the NASCAPE team, as Bob mentioned, I think one of the things that we felt very strongly about was we wanted to provide greater insights. But that greater insights could not be if you had to somehow acquire a bunch of data that you didn't have, or all of these other things that may play into it. So for us, it was, again, back to kind of the streetlight focus. It's what do we have at our disposal already, regardless if it's payer or provider, and what insights can we glean from that? So so we've talked a little bit about the current state. We've talked about kind of grounding this patient-provider relationship. Now let's actually look at some of the work that we've been talking about. Let's look at that in action. And so one of the things that we've, when we talk value-based programs is, one of the fundamental kind of underpinnings is attribution. And one of the things that is often, frankly, a little bit of a pain point that we've talked about over time is this notion of attribution. And so, Bob, talk to me a little bit about the potential of using relationships with attribution models, or how do they play together, or the scenarios that may come about there.
Yeah, well, and as you mentioned, James, certainly attribution is a foundational, if not the foundational methodology when it comes to managing or deploying value-based programs, and we appreciate how critical that is. This is why I think we intended relationships to be flexible, so that organizations have options to consider in how they use them with their value-based arrangements. In one way, relationships can supplement existing attribution results. Instead of using the most recent period of claims or having attribution results be based on the most recent provider interaction, we can supplement those attribution results with relationship strength to then inform which people should be assigned to a provider. And again, that accounts for that longitudinal view of data across many years of data as opposed to just the most recent year or months of data. We've also seen or explored how relationships can be integrated with existing attribution methods and how that informs the actual attribution results. And we can layer relationship strength on top of those results to identify, where weaker practitioner and person connections exist, which may inform whether or not an organization would include or exclude those people from the program. So some of the policies that we have our partners consider is when they're thinking about relationships relative to attribution is, what specialties are eligible for attribution? What are the types of codes that you define as primary care? What do we do about telehealth? And are there certain groups of patients that, as I mentioned, should be included or excluded given their history? And then once these core decisions are completed or defined, we can then make final or help use those decisions to make final patient assignments. The health plan I mentioned earlier is considering how to use relationship strength to identify which people would be included in their performance pool for the new program. The thought that the path they're going down is because it's a newer program and it's potentially more downside risk for the provider. They want to set their organization up, or participants up for success by focusing on patients that are attributed to their care, number one, but also have what we call strong or medium relationships with their provider panel or provider network, I should say. And the hypothesis there is that providers would be in a better position to manage care for people with strong and medium relationships right out of the gate, given the history of their stronger connections with those patients that are part of their care. And also it'd be easier to, number one, incorporate new person-level tags like relationships into their existing workflow, so you're not having to reboot the entire infrastructure that you already have in place. And two, maintain oversight of the people that are attributed to their care with these relationship tags. So the idea is that it's complementary and can supplement existing infrastructure as opposed to having to retool everything. Yeah.
And I think that's important. Another important point I think you just mentioned, Bob, that we should also point out to the audience is the notion of when we have looked at religion, we don't tend to just say somebody has a religion and we don't. We tend to try to stratify it a little bit, and we've used at a high level, strong, medium, and weak. And when you look into each of those levels, you'll see some variation, and you can see some differences within those. But I think it's a lot easier. Bob mentioned a couple of programmatic decisions that he was working on with health plans. It's a lot easier to look at those if you've got those higher grouping categories. And frankly, it allows for a little bit of a common language between the payer and the provider. So we've talked a little bit about, the use case of attribution, but we've also done this work with some of our clients whereby you're kind of hearkening back to what you had talked about in the beginning, Bob, around this notion of looking at the whole person. And so one of the things that we've done with some of our clients is created almost a profile that shows not only the relationship that a person may have or may not, depending on the scenario, with their provider, but it also shows some of the other things that Bob mentioned. What are some of the social indicators? What are some of the clinical indicators? We're certainly not, by virtue of focusing on the relationship side of things, we're certainly not saying that you should de-emphasize clinical at all. In fact, all we're saying is once you bring everything together, it begins to tell a more comprehensive story than if you're simply looking at just the clinical view of a person. The social, the behavioral, meaning how they interact with the system, those all tell a story. And what we've done is been able to kind of consolidate that into a view where somebody can say, I can make a decision here based on some of these other factors that I might not have had visibility to at the appropriate time. So, Bob, anything else you wanted to add on this one?
No, I think you covered the highlights, James. It's really, again, kind of this notion of whole person care, being able to kind of distill that down into in a singular view to help folks tailor or understand what's driving those behaviors for that person. And then you start to see that longitudinal aspect in the events kind of swim lane, which can then inform those relationship strengths and be kind of a mechanism for providers to identify additional outreach tactics that can be taken to either maintain that strong relationship or to improve relationships over time.
The one other thing I will point out on this slide, and I think we mentioned it a little earlier, that once you have the relationship, you can start doing other things with that data. There's a dark blue call-out box there, and you can see we're looking at risk of change. Once you know that somebody has a relationship with a provider, we can then start to use some of our predictives and look at who is at risk of changing. Again, all the more insight that you can provide to providers. If you are certainly taking risks, those are pieces of information you're going to want at the appropriate time, so you can take action and you can engage with somebody perhaps in a different way that makes more sense, for their care in the long run. So, I would just point out that assessing the current state of the relationship is only kind of that first step. Looking at that and managing that over time, because again, we're all human and we behave and interact in our own unique way with the healthcare system, and so you have to kind of look at that over time, and that's where we've mentioned several times the notion of a longitudinal database. That's where that comes into play, where we can constantly look at that over time and see how behaviors change. There may have been a significant life event that drives some of that, and you can start to see that in the data. So with that, we've talked again. We've gone through. We've talked about value-based care in general. We've talked about relationships. We've talked about some of the use cases, whether it be attribution, whether it be using the relationship insight in a different way to engage. But let's talk about what this means from a financial perspective and having to quantify that. Because I think over time, some of the conversations that we've had with our clients, Bob, is this sounds great, but what does it really mean from a how do I quantify a perspective? So can you talk a little bit about the work that you've done and the observations that you've had as it relates to relationships and quantifying them within the context of value-based care?
Yeah, well, and as we talked about, going back to our health plan partner that we mentioned earlier, James, we've got a team of analysts and consultants working with them that have applied relationship strength to their existing value-based care metrics, and we wanted to assess kind of what the variation and differences are between those people that were categorized as having a strong relationship versus a weak relationship. And so our team analyzed, we have access to approximately a database with 2 million people, commercial lives, and we looked at or analyzed data 2019 and prior. We didn't include 2020 just given the likely kind of variation we'd see given the pandemic. So after they kind of compiled those data sets, the team focused on people with strong and weak relationships. And again, those categories were assigned to people based on the consistency and the volume of E&M and provider codes, again, over multiple periods of time. And what we found is that when we look at some of the core metrics that are part of the standardized value-based agreement, things like PMPMs or PMPM by site of service or some quality, looking at 30-day readmissions, for people that were categorized as having a strong relationship with their provider, their cost and performance was lower when we look at those people with a weak relationship to a PCP, or to the primary care practitioner, I should say. And we can see the numbers there on the screen with a 20% reduction, or 20% lower in PMPM, 30% lower inpatient PMPM, and then also 24% fewer 30-day readmissions on a per thousand per year basis. The one thing to point out with the weak, or those that were categorized as having weak relationships, I think that's an opportunity and a consideration for health plans and providers also, in terms of how they go about tackling or engaging those types of people. Because what we've seen is those categorized as having weak relationships is that the utilization is the most inconsistent in that it's dispersed across multiple providers, multiple sites of service, and specialties. So in other words, there's not a clear and concise pattern of utilization that indicates the person is consistently seeking or receiving care from a single provider or team of providers. And then the other consideration is that within that cohort, there are people that simply don't use services. They may have had one encounter in prior years, followed up by another encounter, a couple of years after that. And you may categorize those folks as your non-users, when in fact they may be having additional complications or factors that's driving that behavior. That gets back to this whole person concept of social factors that may be influencing whether or not they're receiving care to manage their clinical conditions appropriately. And the challenge there is that in many cases, those could be like the cases or people that would deteriorate to the point where they would need to receive higher intensity care because their condition escalated to a point beyond management in a primary care situation. So those are some caveats or some considerations I should say when we're dealing with people categorized as that weak relationship tag.
Yeah, that's great. It's good insight. And I guess I'll ask the question that I'm sure some folks on the line are thinking right about now. What's the feedback directly from the market, right? It's one thing for us to kind of do some analysis, but when it's put into play, what's been the feedback thus far?
Yeah, when we're sharing this with providers, James, by way of our health plan partners, and I think the initial reaction is positive. You can start to see the wheels turning in their heads as we get back to that overall theme of kind of refocusing the lens from an encounter or metric perspective to more of a person perspective, and they're thinking about how they could leverage relationship strength with their existing analytics, and really in an effort to maintain that visibility on the patients that they would be accountable for within this new program. There's certainly a lot of discussions to have yet, but I think they're viewing it as an indicator of people that are at, number one, higher risk of receiving services outside of their system, which gets back to that kind of leakage concept. Two, at risk of being attributed to another provider based on the presence of utilization. So that's part of that factor too, in that both of those results could have a potential negative impact on the provider. Number one, from a cost of care perspective, due to increased costs when services are delivered outside of their system, and the fact that they wouldn't maintain visibility and a higher degree of stickiness, if you will, if those attributed people are receiving care outside of their system. And then two, we mentioned earlier that front door system revenue is escaping from their system as well. So, and it's going to one of their competitors. And then finally, the other piece is just that they're thinking about how relationship strength can be viewed as the umbrella for people with multiple chronic conditions and their various chronic condition programs, and start to think about those additional risk factors of the whole person that we've talked about, from social and treatment and clinical burden, that they can start to use views like that person profile that we looked at earlier in conjunction with existing analytics to help drive some of that activity from a care engagement perspective.
Yeah, I'll echo what you said in terms of feedback. My experience has been, some of the folks are looking at this and saying, how can we use relationship strength as another data point in order to, expand programs that are already in existence? So I think it's more of using this, again, I think you mentioned it before, using this to strengthen programs that are already in place. Okay, so appreciate everybody's time today. We're going to wrap up real quick and get to a few questions. But before we do, just to kind of summarize kind of what we talked about today, we led with this notion of the streetlight view. We often will look at where the light is, and sometimes I think expanding beyond that leads to some greater insights and can impact the actions that we take. We talked a little bit about relationships and how those can help strengthen value-based care programs. Looking at things from a longitudinal perspective, getting the view of the whole person as opposed to the clinical action only can really open up some opportunity in terms of engagement, but also, as Bob mentioned, look at a more consumer-centric healthcare approach. And then finally, and I think it's important to state, actionability. You need to have it built on data that is readily available, that can be deployed, that can be incorporated and integrated with existing programs and relationships, and use those analytics that are already there. So with that, so these are the next steps. You'll get some follow-up from us, certainly. But Brian, I'm going to turn it back to you for any of the questions that we've got from the audience in the time that we've got remaining.
Absolutely. Thank you so much, James and Bob, for that insightful and engaging conversation. We will now begin today's question and answer session. As a reminder to attendees, please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll get through as many as we can. So the first question I'll put out there is, the attendee asks, most hospitals use hospitalists that have, at best, a weak linkage to the patient's primary medical doctor. So how do you better connect to the hospitalists to the primary care doctors for the sake of the patient? Patients continue not to understand why they're not seeing their primary care doctor in the hospital.
I'll take a shot at that one, and then Bob, you can add in if you want. I think what we tend to look at is, I don't know that I'm necessarily not necessarily directly connecting the hospitalist, but I think what we've seen is over time, and this goes back to kind of that longitudinal view, you're going to see the pattern that people engage with multiple providers. And ultimately what you have to do is you have to decide which of those providers has the preponderance of the activity to establish the relationship. And so I think that's what Bob was talking about earlier. There's some decisions that you make, and some of that goes into the provider types. Some of that goes into the conditions that somebody may have at that time if they're dealing with a chronic condition. So their primary care might be, you may be seeing an oncologist far more than you do with, your normal primary care physician for a period of time. So there's some factors that you need to take into consideration there. So it goes into not just hospitalists, it goes to all provider types of, we're looking at it over time to make sure that we are, really kind of getting at the appropriate triggers for those relationships.
Got it. Thank you for tackling that one. The next question I'll put out there is the attendee asks, we can't change our attribution model. How can we still use relationships with existing methods?
Yeah, and this is Bob. I can take a shot at that, Brian. I think, and we kind of touched on this during the discussion, but, again, we appreciate how critical attribution, the process of attribution is to existing programs. And so if there are situations where the attribution methodology is what it is, CMS would be a great example in that MSSP program has its methodology, so it's very likely not up for debate on whether or not we change that. But relationships, I think, can help enhance those attribution results, and by helping organizations identify those patients that are attributed but may not have as strong a connection based on their utilization history with those providers that they're attributed to, and by incorporating the relationship strength with those attribution results, that may then lead to a more coordinated and enhanced kind of care or patient outreach approach when they're engaging those particular patients that are attributed to them.
Thank you for that, for those clarifications there, Bob. The next question we'll go with is, how are organizations consuming using relationships with their existing analytic platforms?
Yeah, I can take a shot at that one.
Yeah, go ahead, James.
Well,
go ahead.
I'll start, and then you can go.
Perfect.
What we've seen is, and I think I alluded to this a little bit at the end, where we've got several clients that have outreach programs that are already in place, and often that's some level of a chronic care management program. But what they're trying to increase is greater engagement, and for them, using the relationship status was a way to understand where they can kind of focus their resources, quite frankly, because if they know somebody doesn't have a strong relationship, they can focus their energy there. If somebody does have a strong relationship, they know they're going to have to kind of take a different approach. And so that fits right. That's nothing more than them seeing the data point of the relationship strength within their current application. So.
No, I'd echo that, James. I think, again, we talked about relationships being flexible. We appreciate that there's infrastructure in place with our customers today as well. So if there's an opportunity to leverage the person profiles that we saw a screenshot of earlier, that's certainly an option that we can use to deploy relationships, but also being able to deliver data in the same way that claims are exchanged between organizations. We can deliver those tags so that those elements can be ingested into their existing IT infrastructure and surfaced as they surface other person tags or condition tags today.
Thank you both for tackling that question and the other questions as well. We are running short on time, so we're going to go ahead and close things out today. As a reminder to attendees that submitted questions that we didn't get to, someone will be following up to connect with you on those. So appreciate your time, everyone. Thanks again to James and Bob. It was an excellent presentation and conversation, and thanks to Nascate for sponsoring today's webinar. Enjoy the rest of your day, everyone, and we look forward to having you join us for future webinars.